Whenever you see it, so this is the topics we're going to talk about, just kind of bringing up to speed. Some of this we've had, some of it we haven't. I think I skipped one. Now I'm looking at the list, but apnea testing. Again, this is one of the components of a brain death study. You guys have all had an opportunity, yes, no, to observe a brain death evaluation? Where they go through and they test all the cranial nerves. They go through and okay. Hopefully you'll have that opportunity at some point along the line. It's quite fascinating. Evaluating. They'll take a tissue and touch the eyeball to see if there's a blink reflex. They'll put a suction catheter down to see if it stimulates a cough. So they're looking at all the cranial nerves basically in the process. The last step of this is to go ahead and do an apnea test. And we want to see if the patient develops hypercapnia, which ought to stimulate ventilation, ought to stimulate a respiratory effort. And just if they happen to have chronic obstructive lung disease, you may need to use a different baseline level. Some of the prerequisites, this is kind of who we do brain death studies on. We have to have somebody who has what we're going to call an acute CNS lesion consistent with brain death. So it's some part of the brain that we can identify on a CAT scan that is obviously having some problems, and it's usually about brain stem. No other kind of abnormalities that would cause this to happen. There's not depressants on board. There's no neuromuscular blocking agents involved. Their core temp has to be above 36 because you don't want to evaluate somebody who's profoundly cold, because that in and of itself can suppress brain function. Have to have a decent blood pressure because if they're not stable, you take them off and do an apnea test, they're going to go bye-bye on that one. And we talked about the CO2 using COPD patients or patients with chronic CO2 retention using a different value. So what we do is we pre-oxygenate the patient, put them on 100% oxygen, get a baseline blood gas to evaluate that we have a PCO2 that's in whatever their normal range is, as well as a hyperoxemia. We then remove the patient from the ventilator. A couple different ways to do as far as them. There's one mechanism where we just take a flow of oxygen from the flow meter, the oxygen tubing, and just put it down the ET tube. So there's a continuous flow of oxygen there. Alternatively, some places will just place a patient on CPAP with 100% oxygen. We then go ahead and monitor their saturation and their blood pressure. And what we're really watching for is some respiratory efforts, either abdominal or chest wall excursion, to say that there's a trigger on the part of the patient. If they do happen to have a respiratory effort, and I've been on one where put them back on the ventilator, and we do it another day. As the physician who's at the bedside with me said, I think he's got 3 functioning neurons and 1 just worked. Did the study 12 hours later and it was negative. So, also if they have any kind of ectopic heartbeats, if their SAT drops, if their blood pressure drops, those are all indications that we terminate the test and do it another day. Once we've gotten to the 10-minute mark, we go ahead and do a repeat blood gas. This is an example of where I, in the past, have used, you guys all know what a butterfly is, right? As far as an IV. Start an art line with that and have a little bit of heparin in there to keep it patent. And that way then, when I get to the end of the test, I'm not struggling to try and poke the guy again. I have a ready source available. Once we go ahead and draw that blood gas, we go ahead and put the patient back on the ventilator. And we're looking for a CO2 greater than 60, because that should be an indication that it stimulates enough for them to trigger on. And if we don't see that, so if we see the CO2 elevated and there's been no respiratory efforts, that's a sign of brain death. If you can't survive 10 minutes, obviously, without triggering the ventilator. Cool? Okay. Pulmonary vasodilators. We've talked about this a little bit, but I just wanted to go back through it. These are ones that are used to treat pulmonary hypertension, and we define pulmonary hypertension as a mean pulmonary artery pressure greater than 25. If you remember, the mean pressure is normally around 10, 12, 15-ish. When you start seeing it above 25, that means your systolic pulmonary artery pressure is probably somewhere on the order of 40 torr. So that's pretty significant elevation. And we can do this obviously by right heart cath, putting in a PA catheter, but also they can be estimated by echo. There's multiple groups of pulmonary hypertension, and I won't go through the various reasons, but the primary one here is what's called primary pulmonary hypertension, which is often idiopathic in origin. We don't really know what's causing it, but you got pulmonary hypertension. This is not something that typically we're talking about for COPD patients who have cor pulmonale. It's not something somebody who has chronic pulmonary emboli that are there and causing an increase in PVR. This is ones where the pulmonary vasculature just wants to constrict. Okay, so there's actually 5 different groups, and go beyond that one. Multiple ways that we can go ahead and treat this. Everything from calcium channel blockers, things like diltiazem and nifedipine are common calcium channel blockers, often used for treating systemic hypertension also. Prostacyclins, and the one that I want you to know is iloprost. We've talked about it before. We talked about pharmacology. It is an inhalational drug that is administered to treat pulmonary hypertension. Your PDE inhibitors, you may recognize them from other origins. Sildenafil is better known as Viagra, but it's also used to treat pulmonary hypertension. I think that should be endothelin receptor, whatever, but they're oral. And then there's soluble guanylate cyclase stimulators. Never heard of them before, but the one I want you to know is iloprost. It's a prostacyclin that's inhaled that treats pulmonary hypertension, and they're usually indicated when you have profound dyspnea at rest. Okay, so these are folks that are pretty much the pulmonary hypertension is so severe that it's impeding their ability to ventilate, and they're often in congestive heart failure secondary to it also. Okay, skin testing. Why they have a chapter on this or this section on this, I'm not entirely sure, but let's talk. We either do skin testing for Mycobacterium tuberculosis, or we do it for allergy testing. If we're doing TB testing, we know it's a small amount. You've all had it done on yourselves. About 0.1 milliliters, or about 5 units of what is known as a purified protein derivative, PPD, injected intradermally on the volar surface of the volar. What the hell is see, there's the palm side of the forearm. And if exposure has occurred, it's going to have a hypersensitivity reaction. And this hypersensitivity reaction is a delayed one, so that's why we wait 2 to 3 days to have it read. And it's that diameter of induration in millimeters that we are concerned ourselves with, and greater than 10 is considered positive. No induration is considered negative. What a novel idea. There can be false positives. Those folks who may have had the BCG TB vaccine, in a lot of foreign countries, they vaccinate against tuberculosis by giving a small amount of tuberculosis. So you'll always have a positive skin test, in which case they would have to have a chest x-ray. The other one having to do with skin testing for allergies, and these are IgE-mediated style. And there's really 3 components that are there. We identify the potential allergen, and this is often done through history. We demonstrate specific allergies by doing the skin testing. Can do blood testing also, but normally it's just a scratch testing. And then we determine the allergen exposure results and symptoms by history, or we can actually do a challenge procedure if need be. Lots of different allergic things that we can test for what it's worth. The one that we should be familiar with is ones that are done for allergic or atopic asthma, and they're basically both indoor and outdoor allergies, dust mites, hay fever, or that's what I'm looking for, hay fever. We don't routinely do it on somebody who's at high risk for an anaphylactic reaction. Not good idea. And those who are on some IgE-mediated immune response, there's multiple drugs that are there. You should be familiar with Omalizumab, Xolair. It's a whole lot easier to say. That's if you remember back from 1140, that's the asthma drug that is done for severe persistent that are unresponsive to steroid therapy. It's a shot that is given every couple of weeks. There are some contraindications that are there, but for the most part, that's a simple way to be able to determine what somebody is allergic to. We typically use either a skin prick or an intradermal injection, and I would never test you on this, but you kind of get an idea of what they're doing, placing this allergen. They have a small spot where they put some histamine as a control, and then the other ones are, because we know that we're going to get a reaction from the histamine, for each of the other ones then it's compared to that histamine reaction. And we're looking for a wheel that's greater than 3 millimeters or as large as the histamine one as a control. ICP monitoring. We know that there is a pressure inside the skull in the brain tissue, blood, and cerebral spinal fluid. It's determined by an autoregulatory function between blood flow, vascular tone, and CSF fluid production and absorption. Lots of indications for it. The one that we're going to primarily see is that first one, traumatic brain injury, where you have a Glasgow Coma scale that's on the low end. But you'll also see it on somebody who has a potential for a traumatic brain injury, even though their CT scan is normal, if they have some other things like hypotension present and posturing. Yeah, lots of stuff to indications. No real absolute contraindications, but patients who are known bleeding disorder, you gotta weigh pros and cons, or if they have a CNS infection or a meningitis of some kind. Two main methods that we use, either replacing a catheter into the ventricle or replacing the catheter directly into the parenchyma. The interventricular is the gold standard because it's a global ICP, where if you're looking at the interparenchymal probe, it's only looking at a localized measurement, so it makes sense. We used to use what are called subarachnoid bolts. That just sounds wrong. And literally, it was a screw that they screwed in through the cranium after drilling a burr hole. Screw the bolt in, and we'd be able to measure it. These are a little more kind with just a smaller hole and just put a catheter into there. And it's affected by position, so as we change the head of the bed's level, we're going to change the ICP. Bringing the head up will actually lower the ICP. Normal value you should be aware of, 7 to 15. And when we start seeing it get above 20, it's a bad thing. And there is some variation, just like CVP has some variation in value, wedge pressure has some variation. Same is true here. So we see a fall during inspiration and rise during exhalation. Kind of what the tracing would look like. What we're really looking for is cerebral perfusion pressure. This is the pressure, the high end versus the low end. So what's the delta that we end up seeing there? Normally, if the CPP is between 60 and 100, that's a good thing. Once it gets below or above, that's problematic. And the way you calculate CPP, cerebral perfusion pressure, is taking the mean arterial pressure, subtracting it from the ICP. So it's a pretty simple calculation to make at the bedside. And we want to see it so that it's not either drastically low or drastically high, because that can cause some problems with brain damage or death. This is what might cause the ICP to fall. If there's a reduction in volume that is there, if we have the first number, the MAP being low, the value itself is going to be low. And as we hyperventilate hypocapnia, that causes the ICP to fall. That's why we do selective patients alveolar hyperventilation to drive the PaCO2 down. Lots of reasons why ICP can be high, both from the sense of the volume of brain. In other words, if we have a lot of swelling going on, that's why it ends up with, remember, the skull is a fixed space. You get a little bit of swelling in that brain that's going to drive that ICP pressure up. Same is true if I have bleeds, either epidural, subdural, or interparenchymal. Remember, there's that dural layer, and you can either be between the skull bone and that layer, or just below that layer, subdural. We can have problems with restricted venous outflow. So if for some reason or other the CVP is drastically elevated, it's going to back right on up into the jugular veins, and eventually it's going to prevent draining of the fluid from the brain. And there's some other ones that are there that make sense. So if I have a high ICP, I can try things like repositioning them. These are things that can cause an increase in ICP. Trendelenburg position, common sense stuff. Intubation, suctioning, coughing. High levels of PEEP, high levels of ventilator asynchrony, and even doing something simple like doing a recruit maneuver. Probably not a good candidate would be somebody who is a traumatic brain injury patient. This is when we're talking about the therapeutic hyperventilation, where we want to drop the PaCO2 down. But again, you reduce the blood flow to the brain, good idea, reduce ICP, but you also reduce blood flow to the brain and oxygen delivery, and you can get some ischemic parts. Interestingly, for patients with TBI, we should avoid this for the first 24 hours until we can get a clue on it. We also should always have an ICP in place to be able to monitor to make sure that it's doing what we think it's doing. And again, therapeutics should not be used prophylactically in patients who have brain herniation, because it's only going to worsen the problem. And it's only good for a few hours. It's not good for days and days and days, which is, I'll be honest with you, years ago we used to leave patients in this for 4 or 5 days, and it's like, oops. This section, I'll be perfectly honest, I have never seen this. And has anybody seen pulmonary ultrasound at all in the ICU? Who's at St. John McClone? You guys are, right? If you see Dr. Burke, ask him about it for me. Because if he's doing it, I want to come in and watch. I hate ultrasounds. I can't see the damn thing on. It's just me. I've had, they actually did an echo on me for my staff. I said, let's do an in-service on echocardiography. This is when I was at Bon Secours, and the part of the department was echo. And they're saying, yeah, see, here's this valve. No, I can't see a damn thing. But the two things I want you to recognize is that we can identify pneumothoraces, and we can identify pleural effusions, and the extent of them. So this is what it's looking at. It's looking at an intercostal space, so we're going between the ribs, and we're directing that transducer to be able to identify the pleural, the parietal pleural, the visceral pleural. That's that solid white line, and then there's this lung below it. Okay, I'll take your word for it. And there's this mechanism. What you should see is that as a patient is ventilating, you see what is called a gliding sign, and I'll show you a short video that has a little bit better involvement with that. And you have a little bit better, obviously, because the greatest amount of volume is going to the bases. You're going to see that lung portion expand in the lower thorax more so than in the apices. And if you don't see lung gliding, that's an indicate. If you see lung gliding, that means that you don't have a pneumo. Obviously, if the lung is inflating and deflating, you should be able to pick up on that. So let me play this short little video. This is showing the gliding, I think. You can see how it's shifting back and forth as the patient's breathing. Normal lung sliding. You can also look at the upper quadrant. So here they're directing the transducer past the liver, looking at the diaphragm and then the lung above it. In this way we can identify pleural effusions.
Hello, my name is Phil Pereira, and I'm the Emergency Ultrasound Coordinator at New York Presbyterian Hospital in New York City. And welcome to Soundbites Cases. In this module, we're going to look specifically at ultrasound of the lung to evaluate for pneumothorax. Interestingly enough, a classical belief was that the lung was not optimal for ultrasound imaging. However, newer findings have shown that actually ultrasound is an excellent modality for viewing the pleura and for detecting pneumothoraces. There's been a lot of research looking at this, and what's interesting is that ultrasound has been found now to be more sensitive than chest X-ray in the diagnosis of pneumothorax, especially in the supine trauma patient. And now we're going to add on use of the lungs looking for a pneumothorax as part of our extended fast exam, or the E-fast exam that we'll be performing in trauma patients. We can also detect pneumothoraces as well in our medical patients. Now let's learn how to perform the ultrasound examination for the pneumothorax detection. Here we have the high-frequency linear type array probe positioned on the anterior chest wall at about the mid-clavicular line, looking into about intercostal space 3. Now in most cases of pneumothorax with the patient supine, the air would be predominantly seen in this area. Note we're looking in a long axis configuration between the ribs with a marker dot oriented superiorly towards the patient's head. Once we've identified both the ribs and the pleura, we can swivel the probe into the short axis configuration to further look at the pleura and to detect pneumothorax. Here we have the probe oriented in a transverse or short axis orientation between the ribs, looking directly down at the pleura. Notice in this case, the marker dot is located towards the lateral aspect of the patient. Using both long and short axis configurations will allow you to detect a pneumothorax with a high degree of accuracy. If no lung is seen on the anterior chest wall, one can size out a pneumothorax by looking in the lateral positions as shown here. Notice the probe on the lateral chest wall in the short axis configuration between the ribs. If lung is seen here laterally, but not anteriorly, this would tell you it was an incomplete pneumothorax. We can complement the short axis view by locating the probe into the long axis configuration with the marker dot towards the patient's axilla to further examine into these lateral areas of the chest wall. Here's a nice pictorial showing the normal findings of a lung in a long axis type configuration. Superior rib to the left, inferior rib to the right. Notice that the ribs cast shadows posteriorly due to the inability of the sound waves to permeate the hard calcifications of the rib. We see the chest wall anteriorly, and note here the two layers of the pleura. And we see here the outer parietal pleura and the inner visceral pleura. Now, while I've depicted these as two separate layers, in reality on ultrasound examination, they're seen as a single shimmering white line that moves back and forth as the patient breathes. And as the patient breathes, we can see white comet tails or linear lines, vertical lines coming off the pleura down deep into the lung. So that will be the normal finding of a lung on long axis configuration. Here's a nice ultrasound image showing a normal lung, and what we see here, we're in the long axis configuration, so the superior rib is to the left, inferior rib to the right, chest wall anteriorly, and we see here the lung sliding, which is the opposition of the outer parietal and the inner visceral pleura, and we see the vertical comet tails coming off the back of the pleura. Thus, this is a completely normal exam, no pneumothorax. But note the location of the pleura deep to the ribs, and that classic shimmering line back and forth as the patient takes a breath. Here we see more dramatic comet tails coming off the shimmering parietal and visceral pleura. In this patient, we see the comet tail shooting off the back, telling us that this lung is up and there's no pneumothorax. So vertical lines coming off the back of the pleura always mean that the lung is up and are always a good sign on lung ultrasonography. As we mentioned, we should also swivel the probe into the short axis configuration to further examine the lung. And what we see here is a normal lung in short axis configuration. Note here, we're looking in between the ribs, so all we see is the dome of the lung, and notice that it slides back and forth as the patient breathes, and we see the vertical comet tails coming off the back. So a completely normal examination in the short axis plane. Here's another ultrasound image taken from the short axis configuration. Note here we see very prominent comet tails coming off the back of the lung as it slides back and forth. Again, it's that opposition of the parietal and visceral layers of the pleura that allow the lung shimmering, but notice here all the comet tails coming off the back. In this case, this patient had some pulmonary edema associated with the lung, and these comet tails are more pronounced due to the presence of water within the pleura. But notice all these vertical lines coming off the back telling us this lung is up. A way to document that the lung is up, to print out for the chart, is to put M mode, and generally what we do is locate it so the M mode cursor is down right at the pleura. And what we see is the classic seashore sign, or waves on the beach. If we look anteriorly, we'll see the classic waves, or no motion of the chest wall, and below that, deep to the pleura, we'll see the positive motion of the lung making up the beach. So waves on the beach, or the seashore sign, and M mode documentation that the lung is up and that there's no pneumothorax. Now that we understand what a normal lung looks like on bedside examination, let's take a look at a pictorial showing a pneumothorax in a long axis view. We see here that the parietal pleura is now split from the visceral pleura, which is attached to the lung, by a layer of air shown by the yellow color. It's the splitting of the parietal and visceral pleura that now causes a lack of lung sliding, and instead of the opposed visceral and parietal pleura sliding back and forth as the patient breathes, all we see is a single line, the parietal pleura, with a lack of vertical comet tails coming off the back. Here's an ultrasound image taken from a patient who was stabbed to the left chest and who had shortness of breath. What we see here is a long axis view of a pneumothorax. Let's take a look at the chest wall anteriorly, and right below that we see the parietal pleura, a single white line located directly inferior to the ribs, but notice the classic lack of the lung sliding. All we see here is a single white line that fails to slide back and forth as the patient breathes. Notice also the absence of the vertical comet tails. Here's another image of a pneumothorax in a long axis configuration, and we see here the chest wall anteriorly and the single white line which is the parietal pleura. Now this patient was acutely dyspneic, so notice that there is some motion of the chest wall and that the parietal pleura moves up and down, but notice the failure of horizontal sliding. Notice also the absence of any vertical comet tails coming off the back of the pleura. Now let's inspect a pneumothorax from the short axis view. We see the chest wall anteriorly, the parietal pleura as shown as a single non-mobile white line in the middle of the image. Note the failure of movement back and forth, the lack of vertical comet tails, and what we see here is repeating horizontal air lines from the pneumothorax. To document the absence of lung sliding and the presence of a pneumothorax, we'll again turn to M mode. If we put the M mode cursor down on the pleura, what we'll see is a set of linear repeating lines. This documents no motion of both the chest wall and of the lung, making up a finding known as the barcode sign. Here's a pictorial showing an interesting finding, the signature of an incomplete pneumothorax known as lead point. And what we see is an incomplete pneumothorax with air collecting to the superior aspect of the image to the left, thus splitting the parietal from the visceral layers and causing an absence of lung sliding superiorly. However, as the lung is coming up against the chest wall to the right or inferiorly, that's where we'll see the presence of horizontal lung sliding and the presence of the vertical comet tails. Here's an ultrasound image showing the lead point, and what we see here is the lung sliding to the right, the area where the lung touches up against the chest wall, and to the left, the area of absence of lung sliding, telling you there that air has collected between the visceral and parietal layers. So the ultrasound equivalent of the image that we just looked at telling you that this is an incomplete pneumothorax. But here we see that lead point or transition point very well on bedside sonography. In conclusion, I'm glad I could share with you this ultrasound module going over ultrasound of the lung to evaluate the pneumothorax. This is an excellent tool for viewing the pleura and making the diagnosis of pneumothorax, and there's been some research showing that it may be more sensitive than chest x-ray in the diagnosis of pneumothorax, allowing rapid diagnosis of pneumo in both your trauma and medical patient, thus facilitating more timely management of these most critical patients. So I hope to see you back as Soundbites continues.
I don't think so. Here's another one where they're looking at for pleural effusion using this technology.
Hello, my name is Phil Pereira, and I'm the Emergency Ultrasound Coordinator at the New York Presbyterian Hospital in New York City. And welcome to Soundbites Cases. In this Soundbites module, we're going to look specifically at the use of bedside ultrasound to detect pleural fluid. Interestingly enough, ultrasound has been found to detect as little as 20 cc's of fluid within the pleural space. In contrast, a chest x-ray will not reliably pick up less than 100 to 150 cc's of fluid on an AP film. Now, this problem is only compounded in the supine trauma patient, where a chest x-ray may miss a significant amount of fluid, as a hemothorax will layer out posteriorly and can be very difficult to detect on this film. For these reasons, bedside ultrasound may offer a more accurate way of diagnosing pleural fluid. Here's a slide reviewing how to perform the ultrasound examination for detection of pleural effusions. Optimally, you'll have a 3 MHz probe with a small footprint that can easily sit between the ribs, as we'll be looking into the right upper quadrant and left upper quadrant areas. In position 1, we'll be coming into the standard right upper quadrant trauma fast exam and position the probe into that area just above the liver and below the diaphragm. We can then angle the probe upwards into the thoracic cavity to look for a dark or anechoic fluid collection signifying thoracic fluid. We can repeat the exam in the left side as shown in probe position 2, placing the probe into that area of the left upper quadrant trauma fast view. Look first into the area above the spleen and below the diaphragm, and then angle the probe upwards into the left thoracic cavity. If fluid is seen within the thoracic cavity, we can then move the probe upwards to investigate the extent of the effusion. Here's a video going over how to perform the examination. Notice here we have a probe placed into the right upper quadrant trauma fast area. Notice that we're angling the probe upwards into the thoracic cavity to fully investigate for a pleural effusion. Here I'm just superimposing about the level of the diaphragm as shown in the red marker. And notice here that the probe is positioned coming into that area just above the diaphragm into the thoracic cavity. Traditionally, the probe should be in a long axis configuration with the marker dot towards the patient's head. Again, if a fluid collection is seen, one can then move the probe upwards to fully investigate how big the effusion is. To optimize your examination, place the patient with the head slightly upwards so that the fluid will layer out above the diaphragm, allowing earlier detection of smaller amounts of fluid. Now that we know how to perform the ultrasound examination for pleural fluid, let's take a look at a normal right upper quadrant pleural examination. The probe is configured in a long axis type orientation with a marker towards the patient's head. So we see superior to the left, inferior to the right. The liver is in the middle of the image, and let's look above the liver. Here we see the diaphragm, that curving white line which is moving up and down as the patient breathes. And to the left, or superior to the diaphragm, is the thoracic cavity. Now, while looking at the thoracic cavity here, what we see is something called mirror artifact. This occurs as a result of the sound waves coming through the diaphragm and reproducing what looks like a mirror image of the liver within the chest. This is a normal appearance of the thoracic cavity, and mirror artifact is something that will be seen commonly on bedside sonography. Notice, however, the absence of a dark or anechoic fluid collection within the right chest. Now let's take a look at a normal left upper quadrant pleural exam. Again, we're in a long axis configuration, so superior to the left, inferior to the right. We see the spleen in the middle of the image, and we see the diaphragm moving up and down as the patient breathes. Let's look above the diaphragm into the thoracic cavity, and again we see that mirror artifact. What it looks like is almost like a reproduction of the spleen within the thoracic cavity. So this is a normal finding, and one that is not to be confused with fluid. Fluid will appear very differently and will have the appearance of a dark or anechoic stripe right above the diaphragm. Here's an illustration showing a positive examination from the right upper quadrant view with a pleural effusion above the diaphragm. We're in that long axis configuration, so superior to the left, inferior to the right. We see the liver in the middle of the image here, and the diaphragm, the white line, is seen right above the liver. Notice in this image we have a pleural effusion as represented by the dark area of fluid, which is immediately superior to the diaphragm and tucks in there right above the diaphragm, going up into the thoracic cavity. So this would be the signature finding of a pleural effusion as taken from the trauma fast views from the right upper quadrant, and the left upper quadrant will also have a similar view, although we're just looking above the spleen in that orientation. Here's a video clip showing a small pleural effusion as taken from the left upper quadrant view. Here we see the spleen in the middle of the image, the kidney inferior to the spleen, and the diaphragm, the curving white line that's moving up and down as the patient breathes right above the spleen. As we look into that area above the diaphragm, we actually appreciate here the presence of a dark or anechoic fluid collection above the diaphragm. This represents a positive pleural effusion. Notice that the amount of fluid is relatively small, and we can actually see the lung moving up and down to the left of the image here. Here's a moderate pleural effusion as taken from the right upper quadrant view. We see the liver to the inferior aspect, or to the right, the curvy white line making up the diaphragm in the middle of the image, and fluid representing a pleural effusion superior to the diaphragm. Interestingly enough, we see the lung moving around and all the fluid compressed down by the fluid within the chest cavity, taking on what appears like a liver within the chest, and something called hepatization of the lung. And this is commonly seen with a pleural effusion as it pushes in on the lung, making it more of a solid type organ. Here's a large pleural effusion as taken from the right upper quadrant view. And what we see here is the liver inferiorly, the diaphragm right above the liver there in the middle of the image, and we see a large, dark, or anechoic fluid collection immediately superior to the diaphragm. This represents a large pleural effusion. And in the midst of the pleural effusion, we can see the lung waving around and compressed down by all the fluid within the thoracic cavity, again demonstrating that hepatization of the lung as it's compressed down by the pleural fluid. So this would be a large pleural effusion, as there's a large amount of fluid both inferiorly between the lung and the diaphragm, and both anterior and posterior to the lung itself here. Unfortunately, not all pleural effusions will be free-flowing or uncomplicated. There are occasions where patients can have repeated pleural effusions that can be loculated or complicated. Here we see an example of a loculated pleural effusion. Notice this lung here has an attachment with a fibrin area that attaches it or glues it onto the diaphragm inferiorly. Therefore, we have two loculated areas of effusion, both anterior to the top of the screen and posterior. As the lung is trapped within the thoracic cavity by this fibrinous attachment to the diaphragm, it may be dangerous to perform an invasive procedure like a thoracentesis or a chest tube placement. The needle or the chest tube could be guided up into the lung, causing a pneumothorax by the fibrinous attachment to the diaphragm. So in conclusion, I'm glad I could share with you the Soundbites module going over the ultrasound examination for the detection of pleural fluid. As we discussed earlier in the module, ultrasound may be more accurate in detection of pleural fluid than a chest X-ray, and ultrasound allows easy grading of the amount of fluid within the pleural cavity. It can also detect complicated pleural effusions that may be loculated, and can help determine which patients may benefit from a drainage procedure such as a thoracentesis or tube thoracostomy. So I hope to see you back as Soundbites continue thoracentesis procedure under ultrasound guidance.
That was cool, I thought. I want to get one of those. VQ scans you know about are basically our ability to identify where there's a separation between the two. They use radioisotopes. We use xenon for the ventilation component, and typically they'll use technetium for the perfusion component. We'll get a standard chest x-ray along with it, because we're really looking only at a two-dimensional and trying to get an impression of a three-dimensional object. And there's what is used as a SPECT, a single photon emission VQ scanner They can get a kind of like a tomography, kind of like a CT scan that can identify even down to subsegmental abnormalities. We typically use it to diagnose a PE or to predict post-operatively where there's when surgical resection of the lung volume, we get an idea of how much is there. The more accurate test, obviously, is a CT that has some contrast to get an angiography. But if that's not available, or they're allergic to the contrast, you can utilize this. And we take the chest X-ray to see if there's anything physically that would be impeding and ruling that out. We then match that with the VQ scan. We can identify if there's a mismatching of ventilation and perfusion, i.e. you would have some abnormal VQ scan where the perfusion defect with normal ventilation is present. And this is kind of where we can say we have a right lower lobe. If we look at ventilation, it's perfectly fine. If we look at perfusion, there's a whole part of the right lower lobe that is not being perfused, so therefore we have some kind of an abnormality there. Exhaled carbon monoxide, I think Mary went through this. We know that their elevation is present for smokers. And the impression is that there's a way we can do this non-invasively. It would be a whole lot better than having to poke the patient. And expired CO2 is minimally invasive. In fact, it's not really invasive. It's the least expensive way to use to monitor somebody's smoking status. In theory, it could be used for carbon monoxide poisoning, but it's typically not what we end up doing. Calibration is done with we expose it to air where there is no carbon monoxide, so it's 0 parts per million. Then we use a calibrated gas of 50 parts per million as the high point. And if we have problems with calibration, it could be either that there was a bad calibration or the equipment's malfunctioning. And what we're looking for is readings on the high end within 5% of that 50 parts per million. Nope, wrong one. This is just a description of how we end up doing it. You guys did this in the lab, didn't you? Wasn't that one of your labs? Okay. And you just basically have them take a deep breath in and exhale very slowly and fully. And we take a look and see what their CO level is. What's considered normal is debatable, but somewhere in the 6 to 8 parts per million range is considered high, although some people even go into, from the range of 3 to 4. And if they have diseases that are inflammatory in nature, like COPD and asthma, they might have a little bit of an elevation just simply because that's part of the inflammatory process and the release of carbon dioxide. Yeah. Last time I was talking about withholding or withdrawing life support, which we know about. Withholding life support, not starting life support, is either done because there's a do not resuscitate or do not intubate order on their living will. Withdrawing is a little bit different. It's basically where we're considering terminating life support, withdrawing it to allow death to ensue. 3 methods for ventilator withdrawal. I think we primarily do the first one. We just come in and extubate them and let nature take its course. There is some belief that you can use it in a more gradual, either withdrawal to T-tube or just leaving the airway in but allowing them to pass with by terminally weaning them. We take on a lot of that responsibility. Which one you choose kind of depends upon what the underlying process is. If I have somebody who is brain dead, well, that's pretty easy. Just go ahead and extubate them. If I have some patients who have brainstem only injuries, but it's not something where they're brain dead, then we can go to a T-tube and just allow that to gradually have allow nature to take its course. And in terminally weaning patients, you guys have, I'm sure, have had situations where they're not brain dead, they have some function, but we just go ahead and terminally wean them at that point, because the desire of the family, the desire of the patient is not to continue aggressive process. Lots of things that are involved prior to the implementation. Obviously, support to the family is key. We'll have Peg Nelson coming in talking about palliative care, and it's very interesting what they've done at St. Joe's for a lot of their palliative care patients to be able to manage them. But certain things like just playing music, having a nice cool environment, not having a warm environment makes a whole lot of difference. Removing anything that's unnecessary, like an NG tube or blood pressure cuff. We keep the IV in just so we have the ability to provide some analgesia and sedatives, and just make the patient comfort at that point. Having the patient, family come in, and then we go ahead and, regardless of the method, we want to make sure that we have appropriate amount of analgesia and sedation. We usually use opioids or benzodiazepines to accomplish this, although some places use Diprovan, which is a little bit of a different drug. And those are just kind of some of the protocols that are there for management of it. And that's it. Does anybody not